You're all set.
Okay, thank you. Well, good evening, everyone, and thank you so much for joining us. We're presenting tonight our first Ask the Experts program of 2026. This is a program that's jointly sponsored by the Montgomery County Office of Public Health and the Montgomery County Immunization Coalition. We've been doing these programs since 2022, I believe, or 2021, which started during the pandemic in order to be able to present information to the general public on immunizations. We started with a focus on COVID, of course, but we've transitioned now into discussing all immunizations. And tonight, in honor of National Infant Immunization Week, which comes up April 20th through 27th, we are focusing on pediatric immunizations. And we've assembled quite the stellar panel for you today to share information, and particularly these days with all of the confusion and conflicting information that you hear about immunization. I am your moderator for this evening, Dr. Richard Lorraine, the Medical Director of the Montgomery County Office of Public Health. And with me tonight are Doctors Katie Lockwood, Lori Handy, and Jay Rothkopf. We'll start with introductions. Myself, as I mentioned, I am the Medical Director of the Montgomery County Office of Public Health, and I've held that position for just under 10 years. I'm an internist who's practiced in Montgomery County for about 40 years. And in addition, last year I retired from the Air Force Reserve component, where I held multiple positions and had a terminal assignment as the commander of the 108th Medical Group, New Jersey Air National Guard. And with that, I will move on to our other distinguished panelists. I'll start with Dr. Lockwood. So Dr. Lockwood is an attending physician at Children's Hospital of Philadelphia Primary Care in Flourtown. She's also an associate professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She attained her medical degree at Thomas Jefferson University and did her residency at Children's Hospital of Philadelphia, where she was chief resident. She's the host of a CHOP podcast called Primary Care Perspectives and serves as a spokesperson for the American Academy of Pediatrics. She's the co-founder of Pediatric Health Chat, a CHOP website with social media content focused on dispelling medical myths and rumors. Dr. Lockwood.
Thank you so much for having me. I'm also a resident of Montgomery County and the parent of a 12 and a 15-year-old. And I want to state up front, too, that I'm an unpaid spokesperson for the American Academy of Pediatrics. And I'm happy to be here tonight.
Thank you very much. Our next panelist is Dr. Lori Handy. She's an associate professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania, an attending physician in the Division of Infectious Diseases at the Children's Hospital of Philadelphia. She received her medical degree from the University of Pennsylvania, then completed her residency in pediatrics and fellowship in pediatric infectious diseases at the Children's Hospital of Philadelphia. Her early career was rooted in clinical operations at CHOP. Near the end of the pandemic, she turned her attention to vaccine education and became Associate Director of the Vaccine Education Center at CHOP. There, she works primarily to share science-based current information about vaccines with providers through multimedia approaches, while also teaching how to best communicate this information to patients and families. Dr. Handy.
Hi, everyone. Thanks for having me. Like Dr. Lockwood, I too live in Montgomery County. I have two little kids, so I don't know which is the bigger job, the mom or the doctoring, but I love what I do, and it's been a really tricky time talking about vaccines all the time, but I really love getting good information to families, so hopefully we can help you out tonight and get your questions answered.
Thank you so much, Dr. Handy. And Dr. Jay Rothkopf. Dr. Rothkopf is a board-certified internist who has practiced hospital medicine since 2009. He attained his medical degree at Temple University and his residency at Abington Hospital and Temple University. Following residency, he began inpatient practice at Jefferson Health Lansdale Hospital before moving to Life Care Hospitals of Chester County for 5 years. He also associated with a private group at Jefferson Health Abington Hospital before then joining Penn Medicine. He is currently a member of Clinical Care Associates at Penn Medicine, Chester County Hospital. He has practiced full-time there since 2017. Dr. Rothkopf also currently serves as the chairman of the board of the Montgomery County Medical Society. Dr. Rothkopf.
Hello, everyone. Thanks for being on tonight. Happy to be here. So I kind of cross-pollinate. I live in Montgomery County, work in Chester, born and raised in Ambler, Fort Washington, have 4 kids. I'm the only physician who's not a pediatrician, but the issues we're going to talk about tonight also cross-pollinate into adult medicine. And just for anyone who's wondering, the Montgomery County Medical Society is a volunteer organization that advocates for the patients and physicians of Montgomery County. So thank you for being with us tonight.
Thank you, Dr. Rothkopf. So as you can see, we have quite an assembly of experts here tonight, which is, of course, why we call it Ask the Experts. The format for this evening is that we have identified multiple areas of importance in immunization questions that are going on these days. There's been a lot of changes recently, a lot of different information that's coming from different organizations. And we felt it's really, really important to focus on these particular issues to be able to explain why you're seeing the information that you are and what information you can believe, what things that you might want to question. And as always, and I will reiterate this at the end of the program, although we are giving you information to the best of our ability and the best of our motivation, the most important source of information for immunization is from your trusted healthcare professional. Either that, or in the case of pediatrics, for children, from your child's pediatrician. So these are the people who have the training, the knowledge, the expertise, and the desire to help everyone achieve their best health. And these are the best sources of information for you. So with that said, we're going to be addressing several topics in turn. That will take us through most of the evening. Now, while we are presenting these topics, if any questions come up in your mind or you have any questions prepared, please feel free to type them into the Q&A. If we have time at the end, we will take those questions from the Q&A and address them with our panel. Otherwise, we will do our best to answer them at some future point. And having said that, we will move into our first learning area. And the first question will go to Dr. Lockwood. And this I thought really is kind of the crux of the matter for what's going on right now, because we're seeing different information coming from professional organizations and the federal government, notably the CDC. So we've asked Dr. Lockwood to go into detail on how to differentiate between the current CDC guidance and the guidance that we're getting from the American Academy of Pediatrics. We want to talk about the specific diseases that the CDC now classified as shared clinical decision-making or risk-based, while the AAP continues to recommend them as routine for all children. We also want to go into the science behind these recommendations as well. And with that, I'll turn it over to Dr. Lockwood.
Great, thank you. Well, earlier this year, HHS announced through the CDC that they would be changing the immunization schedule, as Dr. Lorraine just mentioned, so that some of the diseases that we used to routinely recommend would go into this category of shared decision-making. And that led to a lot of confusion because people did wonder why this change was made. And it's really important to note that this change was made out of a desire to align with countries in Europe, particularly Denmark, and not made on any new science that had been discovered recently, and no changes in terms of the safety of vaccines. So there wasn't new information that came about to make this change. And because of that, and because we have decades and decades and decades of scientific research that demonstrates that these vaccines are safe, effective, and important for kids, the American Academy of Pediatrics, or the AAP, said that we would not be following the new CDC schedule, but would stick with the same schedule that we've been using for years. So this left parents in my clinic with many questions about, well, do I follow the same schedule, the AAP schedule, or do I adjust to this new schedule that's recommended by the CDC? And so, again, what I typically stress with families is that there is no new science, and although these diseases that were called out specifically in the CDC schedule are in this category of shared decision making, which we'll talk about more later, we've always done shared decision making in that we do talk about the vaccines and make sure that parents agree with what we're giving, but we still strongly recommend protection against the diseases that we can protect kids against. So some of the diseases that fell into this category were things like RSV, hepatitis A, hepatitis B, rotavirus, and then seasonal things like flu and COVID, for example. But we know that hepatitis A, hepatitis B, all of them really are serious infections if your child gets them. And so we don't want to leave any child vulnerable to a disease that we could be preventing when we know that we have a safe and effective form of prevention available. And so that shared decision making is really us saying that in our expert belief, based on the science, based on the research that's out there, and our many, many years of experience giving these vaccines, we still strongly recommend giving them. And that's been the AAP's stance over the past few months since this change was made. It's important to know that some of this conversation is moot because recently a federal judge did rule that this change to the CDC schedule, because it wasn't based on new scientific data, is not a valid change. And we don't know yet what that will mean or what the CDC will determine as a next step. But it is a win for science and a win for the AAP schedule, which is the one that we've believed in all along. So the AAP schedule has been endorsed, this new schedule, which is the same schedule, but us saying that we're going to keep following that, has been endorsed by 12 major medical societies. So all the big medical groups, family physicians, GYNs, everyone's been on the same page that this is the right schedule to be following, as well as many different national parent groups and patient advocacy groups who have also reviewed and noted that this is the schedule that we should be following. So in my clinical practice, even though there's been this change in the past few months on the CDC side, I have not changed my recommendations at all and continue to follow the same schedule that I've been using all along.
And I just forgot to unmute myself as I expected I would. So thank you, Dr. Lockwood. So that gives us a good lead into this shared clinical decision making. What is that? What does it mean? What is that process? It's been presented as something that is new and empowering by the CDC, but as Dr. Lockwood mentioned, it's something that we've been doing for quite some time. So I'm going to turn to Dr. Rothkopf to define the use of that term as how it's used in clinical practice, and explain also why sometimes making universal recommendations for routine administration is a better public health practice. Dr. Rothkopf.
Thanks, Dr. Lorraine. So to build on Dr. Lockwood's comments, believe it or not, the concept of shared clinical decision making has always been there in the patient-physician relationship. If you go back 50, 60 years, there was something different that we called paternalism, which was the idea that the doctor would make a recommendation and the patient would follow it without question. And that has certainly evolved since, the 1950s, 1960s, as information has exploded, become more available. And really, it means partnering with our patients to discuss risks, probabilities, the science behind the recommendations we're making, and why what we say is what we believe based on the evidence to be the best course of action. And it's important to distinguish true shared clinical decision making from the idea that we're simply empowering opinions. Shared clinical decision making, first and foremost, is grounded in fact. And the recommendations for vaccines come from decades of evidence, from high quality research, what we call randomized controlled trials, which is the highest quality of evidence, where we compare what we're testing against the placebo, and none of the researchers know who's getting the actual vaccine in this instance and who's getting the placebo, so we can look at the effect without bias. We discuss the risk, we discuss the benefits, and of course, patient autonomy must always be respected. There are many reasons why one may be uncomfortable with the vaccine recommendations, but first and foremost, it's an understanding that we're proceeding from a foundation of science and fact. Now, Dr. Loren alluded, to the idea of universal recommendations. So, universal recommendations involve the idea that some diseases are best protected against by, and Dr. Lorraine, please feel free to jump in if as a public health expert, I'm not presenting this correctly, but the concept of, for example, herd immunity. So the more people are vaccinated against an illness, the less chance an illness has, especially a virus, for example, to penetrate into a population. So even though someone might be at low risk, you can become infected. And we saw this with COVID. A lot of infections were asymptomatic. People became infected and they were able to spread it, but they never had any symptoms. And that was one of the ways the virus spread so quickly. So the concept of herd immunity is that the more people who are vaccinated, the more of a shield you have against the virus spreading to individuals who, cannot get the vaccine or have weakened immune systems, or you're not comfortable taking it. So it protects everyone in that sense. And that's one of the reasons, one of the main examples for the idea of adhering to universal vaccination guidelines. And we can always all draw analogies, for having tools to lower the risk. Dr. Laura and I were talking before we got on the call, and it said we can get on the most modern airplane imaginable with the best safety and new computers and whatnot. You still want to wear a seatbelt. You might hit turbulence. You might have something unexpected. So if you approach it from that paradigm, that's one of the best ways of looking at the universal vaccine recommendations and why we still wish to adhere to them.
Yeah, if
Thank you,
I
Dr.
can jump in and just give a tiny bit more framework also for the families to understand, what the ACIP, the committee that advised the CDC, used to be thinking when they used that term universal versus using the term shared clinical decision making. On the immunization schedule, if you look in the weeds, and this is no one wants to read the fine print, but shared clinical decision making was really almost an adjective to describe the type of recommendation. And it was reserved for those vaccines that were considered safe and effective, but it was unclear from the balance of evidence if it was effective for the entire population at large. And so those recommendations were for very specific circumstances, like an HPV vaccine in an older adult who maybe had had a monogamous relationship, but now is going to have new sexual partners at a later time in their life and never got vaccinated. These very, very nuanced scenarios, which are very different than scenarios that every single person would encounter. So when you talk about hepatitis A, why is that a universal recommendation? That is because across the board, hepatitis A can be acquired by food. And as long as you're a human living in the United States eating food, you're in the risk category. So there were only a handful of vaccines that had these tiny shared clinical decision-making recommendations. And that term was used totally differently than the concept of clinical care, shared clinical decision-making. And I think the committee, the more recent committee, just really didn't appreciate the intention of that description and jumbled a bunch of words and made it very confusing. But it really used to be a very well-intentioned term, and now just makes it very confusing for families. But, as Dr. Lockwood said, hepatitis A, flu, these are things we're all at risk for just by being humans, and things that our kids are at risk for by being out in the population, playing with their friends, eating food, eating frozen strawberries. These are things we want to protect our children from.
Thank you for that clarification, Dr. Handy. Thank you, Dr. Rothkopf, for the further explanation. And Dr. Handy, that gives us a great lead into your next question, which is to talk about a specific vaccine that went from a universal recommendation to a high-risk recommendation, and that is RSV, or respiratory syncytial virus. So we want to understand why or what was in the mind of CDC and ACIP with this updated guideline for RSV immunization or treatment in infants. And that would include the use of clesrovimab for prevention of RSV.
Sure. So I think in the past few years, seeing a few different strategies come out to be able to protect infants from RSV as a pediatrician was a game changer. RSV is the most common reason for children to get admitted to the hospital for a respiratory infection, and RSV, or respiratory syncytial virus, infects all children. So this is not a kids in daycare. This is not a kids who travel. This is every single child by the age of 2 will get infected by this virus. So, when you again look at risk, they're all at risk. And when we look at kids that get hospitalized, because so many kids get hospitalized, the majority of children hospitalized are otherwise healthy children. They are not high-risk children. They are not the premature children or those with chronic lung disease. These are perfectly healthy little precious babies that don't need to go to the hospital anymore. So now we have 2 strategies to protect them. One is for mom to get an immunization, a vaccine during pregnancy. I don't typically use trade names, but in this, it's important. It's a Brisvo, and that's important to know because there are other RSV vaccines on the market. We want moms to get the right one for them. And if mom gets vaccinated, makes antibodies, those antibodies pass to the baby's born, and from the first second of life, they're protected. So it's December and your baby comes out and toddler sib wants to give a kiss, that baby's already protected, which is amazing. The other option is to use a monoclonal antibody, fancy way of saying a bunch of immune cells that can just get given directly to the baby to protect them. Their immune system doesn't even have to work yet. We just give them immunity through their immunization, and they can get that in a well baby nursery or their first visit to the pediatrician, or if they're born a little before RSV season, usually in October at the pediatrician's office. There are actually 2 available now, and so they're called either clesrovimab or nirsevimab, and again, they're available really across the board and covered by insurance now, which is great. So RSV, if you've had a child who's had it or your friend's child has had it, I know my son had it, and it was really one of the scarier nights of my life. This is just something that now our kids don't have to go through. Might they get mild infection? Sure. Runny nose, a low-grade fever, that's okay. Maybe a visit to the pediatrician. But what we're really trying to do is keep them out of the hospital, keep them out of the ICU, and help them live their little healthy lives.
Great. Thank you, Dr. Handy. Okay, Dr. Lockwood, coming back to you. We're also going to talk now about another specific change in a vaccine, and that would be the HPV vaccine. So there has been a recommendation for 2 doses of the HPV vaccine, yet the latest guideline from CDC changed that to 1 dose. Can you go into the information behind that and what might prompt that decision?
Sure, I will try. Dr. Handy probably knows way more about this than I do. But my understanding is that there are some more recent studies that show effectiveness of 1 dose of HPV vaccine. And so there was some thought about, could we get away with just 1 dose and not have to give 2 or 3, which had been the recommendation. So I'll step back for a second. The current recommendation is that you can get the HPV vaccine starting at age 9. And this is a vaccine that prevents cervical cancer, but also other cancers of the genitals and the head and neck. And so any cancers caused by HPV. So it's a really amazing vaccine because it's a cancer prevention vaccine. And the idea is that you give children this vaccine before they're ever at risk for getting HPV. So a lot of parents think, well, my child's not sexually active, so why are we talking about a sexually active vaccine? And the answer really is that that's exactly the point, is we're trying to get it to them before they're sexually active. but also we're thinking about when their immune system works best at responding to the vaccine. And what we've found is that it responds better when you are a little bit younger. So, in that as early as 9 year range up until 15 is really when you're getting the best response. So, earlier is better. After 15, it still works, but it takes a little bit more to get that same immune response. So instead of 2 doses, you get 3 doses. So that's what we had been doing, is giving 2 doses if you're getting them in before 15, and then after 15, we were giving you 3 doses. But again, some of these newer studies were suggesting that maybe 1 dose is enough, especially if you're giving it earlier when the immune system is stronger at responding to it. But while this decision was being thought about, the ACIP also changed over. So we lost all of the members of the ACIP who were the scientists and the experts who had actually been thinking about this exact question for a long time. And we got a new ACIP that didn't have as much experience in studying this vaccine. And so that was one of the big concerns about making a change, because we don't want to leave kids vulnerable to cancer, right? So we don't want to take away a dose of a vaccine unless we are entirely sure that 1 dose will be as effective. And there are some studies, but there's just not enough long-term data, because again, we're protecting you against things that you may be exposed to in 10, 15, 20, 30 years from now, right? You could be exposed to HPV many years in the future as an adult, and we want that vaccine to still be working. So we need to have more studies that look at the long-term effectiveness of 1 dose of the HPV vaccine. And until we really have that answered clearly and have experts reviewing it, the AAP just did not feel comfortable saying that 1 dose would be sufficient. And so the guidelines still recommend 2 doses, and starting earlier is better, starting at age 9 ideally, but getting those 2 doses in before your child is 15.
Great. Thank you for that explanation, Dr. Lockwood. I think this is a really good example of how we are so focused on the evidence. It's very important for us to make that point, that we in the medical community are very, very much focused on the medical evidence for these things. And we want to make the best objective clinical decisions that we can make based on these studies and this information that we are gathering. All right, so moving on to our next topic, and this is a big one. So Dr. Rothkopf, this one comes to you. Now, Dr. Lockwood had mentioned that there was a recent court decision that seemed to make things a bit different. We're going to have Dr. Rothkopf explain that to us a little bit more. This happened very recently on March 16th in the U.S. District Court for the District of Massachusetts. There was a preliminary injunction issued in a case which was primarily brought by the American Academy of Pediatrics, but multiple other professional organizations also joined in this lawsuit versus the U.S. Department of Health and Human Services. And it had to do very specifically with any changes in the ACIP, the Advisory Committee on Immunization Practices. That is a part of the CDC that makes the recommendations for what vaccines we're going to give to people. So I'll ask Dr. Rothkopf to go into this court decision and what it means.
Thank you, Dr. Lawrence. So the court decision was a stay. I want to give a little background on, we'll call it Law 101 here. So we're all familiar with the Supreme Court. We hear about them. They're in the news all the time. But the first level at the federal district court, or what are called federal district courts. So there are different districts that cover different geographic areas in every state in the country. And if you want to file a lawsuit challenging a federal policy, you start in the district court. Now, going back to about 2017, district court judges were issuing what were called nationwide injunctions to block policies for the whole country. This started during President Trump's first term. Plaintiffs were doing what was called forum shopping, where they would find a judge that they thought would be friendly and would issue a policy, or issue a nationwide injunction. When President Biden won in 2020, the opposite happened, or the same thing I should say, on the opposite side of the aisle. So there was a slew of these nationwide injunctions. So the Supreme Court finally last year issued a ruling saying we're putting a stop to these nationwide injunctions. It's just creating chaos. A federal district court judge can only issue a ruling that covers their district. So what happened in this instance is what was issued was a stay. So a stay is on different legal footing, and it basically doesn't talk about the legal merits of what's being challenged. It's a procedural ruling that basically says what's been done, what's being challenged is being put on hold. So all of these changes that the Vaccine Advisory Committee made have been paused. One little bit of background also, just for education for everyone. Back in the 1940s, when FDR was president, there was a law passed called the Administrative Procedure Act, which governs how the federal bureaucracy works, how the different departments work, like the CDC, the NIH, they're all governed by this law. It involves process, not outcome. So a stay is a different legal path that was not touched by the Supreme Court's ruling, sharply limiting nationwide injunctions. So why is this important? When the Affordable Care Act was signed into law back in 2010, vaccines were under the preventative care mandates. So, when you go to get your kids' vaccines, preventative care is supposed to be covered free of charge. But when the government changes recommendations, insurers now have license to potentially start saying, well, we're not going to cover certain things. And it throws that entire regulatory scheme unfortunately, into chaos. And it's not consistent throughout the country. It depends on who the insurer is. Without the guidance from the federal government, all of a sudden you have a potential patchwork of not only recommendations, but coverage schemes, depending on what the insurance is. So this can be a barrier to care, especially for lower income families, people who live in rural areas that may have limited access to healthcare providers. The ruling itself is likely to get appealed. It's likely to end up in front of the Supreme Court, who, will make likely a merits ruling, although they're not obligated to make a merits ruling. They can simply say yes or no in the technicality and send it back down. But that's probably where it's heading. But take home point, in the meantime, all of these changes that they made are on hold while the litigation plays out. One last point before I stop talking is the next level up from the district court is the appeals court for whatever circuit the district is covered by. And the appeals court has two layers. Usually when an appeal is made, a three-judge panel will hear the appeal and rule yes or no. They agree with the plaintiffs or they reverse the appeal. So this could be upheld on appeal. It could be reversed on appeal. Either party can then request what's called an en banc hearing. The appeals court's actually 15 judges, or they can appeal directly to the Supreme Court. So the timeline here is potentially in flux. But as of right now, the changes have been put on hold.
Okay, so I feel now, in addition to a medical education, we've gotten a legal education tonight. Thank you, Dr. Rothkopf,
My
for
pleasure.
the detail on that.
Thank you. This is something I dabble in. So, yeah. Thank you.
Yeah, so that worked out well. So the important points for us, as Dr. Rothkopf mentioned, all of those changes that came through at the beginning of this year on the 2026 schedule that came from CDC have been put on hold. And we're rolling back to what was the 2025 recommendation, what AAP is currently recommending. They also put on hold the constitution of the ACIP. Those members are actually not able to meet in a quorum at this point. So they're not able to continue any business that the ACP might have. So that has to be either re-adjudicated or reconstituted somehow. So we're basically back to where we were last year is what it comes down to. All right, so next question, which goes to Dr. Handy. We talked a little bit about decision-making process, and we're going to get down to the nitty-gritty at this point. And when a pediatrician is having that discussion with a parent about their child's immunizations, how should the parent approach that? What kind of information should they be looking for to be able to make an informed, evidence-based decision on what's best for their child?
Sure. So, I think the first thing to normalize is It's okay to have questions. It's right to have questions. Someone's going to inject a clear substance into your child's arm or leg, and you should ask questions about that. So your pediatrician wants that, and they expect that. And I think that one thing that really helps is when parents have done some level of preparation for that visit, either checking with the office in advance, are we getting vaccines today, or going to some reputable resource to look at, what does the vaccine schedule look like right now? And with parents, I generally try to get a sense of, where do you like to get your information? So if it's just internet webpage, there's healthychildren.org from American Academy of Pediatrics. There's our center, the Vaccine Education Center. If it's more Instagram, there's great people to follow that we can refer you to. Definitely Dr. Lockwood's Pediatric Health Chat has a lot of vaccine topics, but there's other folks that, have a good reputation for giving some evidence-based information. If it's a podcast, there's podcasts, so really it's, one, having a conversation with a trusted healthcare provider. Where should I look, so that you feel like you can get the education you need to ask those final questions. If you're like, I don't have time for that, that's fine too. The thing that your pediatrician will always do is definitely have at minimum, a 2-page information sheet that they're going to give you about every vaccine. But also when they say, I really recommend that we do these vaccines today, ask, what are they for? What are they protecting my child against? I don't know that word, pertussis. I haven't heard of Hep B. I don't know anyone with it. Tell me about that, because that's what they're there for. So that's what I think of when, we're really talking about having that shared decision making. It's using your pediatrician as a resource. I find sometimes folks end up in different rabbit holes where they're like, I asked my grandmother, and then I talked to my cousin, and then my neighbor said this, and it's hard to know what's true right now. But the good news is your pediatrician really has great information, and they have resources behind them. Again, AAP, their healthcare system, that can help them get the right information to you. So hopefully with doing that kind of conversation, you can really get the answers that you need and make the right decision for your children. I think really, even though this is, again, such a challenging, controversial time, the thing to remember is your best interest is your child's health. Your pediatrician's best interest is your child's health. So you're really aligned on that and working together to make sure that you avoid diseases that really could bring them harm or pain and suffering. And, you're really aligned on that goal.
Thank you, Dr. Handy. I do want to emphasize one point that you made that is really, really important. It is expected and perfectly appropriate to ask questions. And your child's pediatrician looks forward to that, looks forward to giving you that information. It's a large part of what they do, what they've trained to do, and what they continue to do. So never feel that it's inappropriate to question these, but look to get unbiased information in return that's understandable. Ask those questions and keep asking those questions. We really do appreciate that. All right, so I think the next topic also kind of was referenced before too, when we talked about what the CDC recommendations were for certain vaccines, and that is, how are they paid for? What is the insurance coverage for them, and what other programs, particularly from the federal government, might be available to cover vaccines for those who might be uninsured or underinsured? So I'm going to go to Dr. Lockwood to talk about what we expect, or what we're seeing now in terms of insurance coverage and other programs for vaccines, and what we expect in the future.
Yeah, I think this hopefully is a piece of good news in all of this, which is that even when the CDC made the change to their schedule in January, they said that they would still recommend insurers to cover these vaccines, and that government-funded programs such as our Vaccines for Children's program in the state of Pennsylvania is also going to keep covering vaccines. And that was the biggest question that families had back in January when they came into my clinic and heard about the new CDC schedule. A lot of families were scared that they would lose access to vaccines. They thought, okay, are you not going to carry them anymore? Are they not going to be covered by my insurer anymore? And so we were really relieved that we could reassure them that no, they would still be covered. And at least at CHOP, we would still be providing access to all of the same vaccines. And, the Pennsylvania leadership and government has also supported this, that even if there were changes, that Pennsylvania stands behind the AAP schedule and offering these vaccines for children. So it's so important to know that they are still paid for by your insurance plan. There's no reason that you should not be able to afford vaccines. Now, access is a little bit of an interesting question, because at a place like CHOP, as I said, we are still providing all the same vaccines, the same access to vaccines, and there's no problem getting all of the vaccines that you want that are on the AAP schedule. However, if you're seeing another pediatrician or going to a health center that maybe is following the CDC schedule or changed the volume of the vaccines that they're giving, maybe they cut back on how much they're ordering of some of the others, there's some theoretical concern that access could shift just because maybe they won't stock as many. And so that's where I think the AAP has some concern that the confusion of this new CDC guidance could really impact access in some areas of the country. And we hope that that's not the case, and we haven't seen that locally yet, but we encourage really, again, everyone to follow the AAP schedule and to keep access the same for families. What we saw during the pandemic when we were telling people to stay home, right, is that vaccination rates dropped. Understandably, people weren't coming in for their well visits. And then we did have some rebounding after that. But there are still many vaccines that have seen a drop even in the past 2 years. Things like hepatitis B and flu, Haemophilus influenza. And as Dr. Handy and I have said before, these aren't theoretical risks. These are diseases that we still see in our community all the time. So these are risks that are in the community for children, and we have vaccines that we can protect them against that. And so we want to maintain access and make sure that whenever families are ready to get those vaccines, that they can come in and get them. So if it's not at a well visit, at CHOP, we do things like we have nurse visits where you can come in just for a vaccine. So if you somehow get off schedule and you want to come in and get that vaccine, you can do that as soon as possible. And again, your insurance will cover it. And if you have Medicaid, then Vaccine for Children provides the vaccine for you that way. So there should not be a barrier. But again, the confusion that's been created with the changes at the CDC side, we do worry could limit access if people start to order their vaccines differently based on the few vaccines that were called out as shared decision making. And so we hope that's not going to be the case. But if you are having trouble getting vaccines, again, I would encourage you to reach out to your pediatrician or reach out to the health department to see what resources you can find, or find a pediatrician who has those vaccines for you.
Great. Thank you, Dr. Lockwood. So an additional comment regarding access and coverage for vaccines. Dr. Lockwood mentioned that the federal government, the CDC, even when they made their changes in these recommended vaccines, continued to recommend that they be covered, even if there was no longer a universal recommendation. Within local government, both at the county level, Montgomery County, and the state government at the Pennsylvania Department of Health, our organizations were evaluating those recommendations at that time, and independently, myself through the Office of Public Health and the Secretary of Health, Dr. Bogan, both independently recommended that we continue to follow the AAP guidelines. Dr. Shapiro, we do have a Dr. Shapiro in the county who is the son of our current governor, or who is the father of our current governor, Josh Shapiro. So Governor Shapiro issued an executive order at that time for insurers to continue covering those vaccines. So we've had proactive government, proactive state government as well in ensuring that we continue to have access for those vaccines. And then our next question will go to Dr. Handy. And we've talked a little bit about what the recommendations are for the vaccines, what the coverage is for the vaccines. Now, let's talk a little bit about specific requirements for vaccines, and that's in schools. There are certain vaccines that by act of legislation are required for school attendance. So is there any change in those guidelines, in those particular legislated requirements that have occurred since the change from the CDC?
Sure. So good question. So I think, this is a great moment, both on the payment issue, but on these requirement issues to remember that immunization guidance is under health departments, which is governed at the state level. So despite the fact that we've had lots of conversations about changes at the federal level here in Pennsylvania and every state in the United States, health is governed at the state level. And what we've seen by our state of Pennsylvania legislature and governor right now is really ongoing strong support for keeping our children protected. So we haven't seen any change in vaccination requirements for schools. And we do allow for exemptions in the state of Pennsylvania. So that is still something that's available for families who have certain reasons to not get vaccinated. But our schools do still require coverage for the infections that we really think about being transmitted within a school setting. Again, crowded places where a bunch of 5-year-olds are hanging out together. So, this is pertussis, this is polio, measles, mumps. These are things that move between kids. Hepatitis B, chickenpox, all things that when we initially developed school requirements, we did for actually 2 different reasons. One was we knew that these were transmitted in school-aged kids, and we would see peaks of disease in that 5-6-year-old when everyone kind of got together, particularly if they hadn't been to daycare. Daycare wasn't as big a thing 20, 30 years ago. But also because it created a moment in time for us to say, for our state's children, for our country's children, this is the moment. If they've fallen through the cracks, if they've missed their opportunity to get their 4-year-old boosters, if they haven't had health care, this is like full stop moment to protect our kids, to say, let's make sure they're all kind of moving into their next stage of childhood protected. And so a really well-intentioned program, I think now seems controversial or people question it, but it's really designed to catch all of those kids who are missing something. So if your child's enrolling in school, they have to be up to date. If they're not, they actually only have 5 days to document that they're going in to get those vaccines that they're not up to date for. And that's on our school nurses, bless their hearts, to kind of get that all worked out and make sure that schools are really safe places for our children to go, and not places where we spread measles or spread pertussis. Like, our kids are there to learn, they're not there to get sick. There are additional recommendations for those of you who have older kids for entering 7th grade. There's an additional dose of the tetanus, diphtheria, pertussis vaccine. And that's because the pertussis immunity wanes a little bit at that time. So it's a good time to get the immune system boosted. And then meningococcal vaccine as well. And then again, in 12th grade in Pennsylvania, kids get a 2nd dose of meningococcal vaccine. All that being said, as a pediatrician, when I hear families say, I really only want the required vaccines, not the universally recommended, I move back in time to say, like, what's our goal here? Our goal is not to meet requirements to attend public school. Our goal is, let's make sure your child has the healthiest childhood they can. And to do that, let's prevent all the infections we can, because nobody wants their kid to have to get an IV for dehydration or spend a few days in the hospital. So while school requirements are here and we need to abide by them, as a pediatrician, I really focus on the universally recommended vaccines, because that's everything your child needs for their healthy childhood.
Great. Thank you for that, Dr. Handy. So we've come to the end of our areas of focus for this evening, and I do believe we have time to cover a couple of common questions that we've received. I'll start out with this one, which I think is kind of pretty basic. We often hear from patients and from parents of our kids that they have concern about all the different vaccines that we're giving at a single visit. Is there any issue if we try to spread those out rather than giving all at once? Is there a problem if we give them all at once? Is it better? Is it worse? And I will throw that out, I think, to Dr. Handy or Dr. Lockwood.
Sure, I can start, and then Katie, you can jump in as well. So our immune systems, our baby's immune systems are wildly impressive. I think about child who's crawling on the floor and drops their toy and then licks their toy, and the amount of things that their immune system battles in that moment is enormous, versus the amount that's in a few vaccines, 5 vaccines, even 6 vaccines kids can sometimes get on a given day. So their immune systems can definitely handle it. And I think that's important for families to realize. They're really seeing very, very little amount of antigens or little particles that are stimulating their immune system compared to, licking the dirty toy. So when families want to spread it out, I say, well, what's the upside of spreading it out? Sometimes families think, well, I might give them less pain or less stress. And what we found out is we actually give them more stress by spacing it out. And then the key thing is that when we've scheduled vaccines at a given time, we've scheduled them at that time because that is the time the baby is most at risk of the infection. And so when you delay something, you just increase the time that they have at risk of their infection. So if they're inevitably going to get a pertussis vaccine, get it as early as possible, right? Don't leave them vulnerable to those infections. And the final piece that folks should know is this is the way we study them. So going back to earlier in this conversation, we're really focused on the evidence and knowing these vaccines were tested together at the same time at these doses. And that's really how you want your child to receive the vaccines, the way they were studied, the way they were intended. When you start going off schedule, you leave them vulnerable, and then you start really just making things up. And that leaves the pediatrician in a really tricky place to say, I don't actually know how to make that up. I'm really just making it up. So maybe I'll toss to Dr. Lockwood, who has to do this in real life every day. How do you answer that question?
Yeah, I love all of what you've said, and yes, I did this yesterday. So, I agree with you. I mean, I think from the AAP standpoint, we give the vaccines when children, as Dr. Handy said, are, when it was studied at that age, when their immune system is ready for it, and when we think we are getting them protected for when they're likely to see these things. So there is a reason for why we're giving different vaccines at different times. It's not just a random, like, we'll give 3 today and 3 in 2 months. And, there's a very specific reason why we're giving those 3 at that time. And at that time, that sequencing. That schedule has a lot of thought that's been put into it, and a lot of research and a lot of expert opinion. So that's one thing. And as Dr. Handy said too, when you deviate from that schedule, that's when I've seen the most mistakes happen, honestly. People get confused about, like, where am I in the schedule? What should I do next? What was I going to give this time? Like, you're kind of making it up. And again, things get missed. And sometimes they're like, oh, I forgot we never got that second hepatitis A vaccine. Like, I meant to do that a long time ago. We kind of forgot about it. A lot of my patients who choose an alternative schedule too, I talk to them about the fact that means coming back to my office a lot more, especially if you're going to do one at a time. You're really talking about, because there's 4 vaccines given at the 2-month, 4-month, 6-month visit, you're then talking about coming back maybe once every other week in the beginning, and then continuing that. Like, who wants to come? I don't want to take my kids to the pediatrician that often. It's like a lot of scheduling. Just sometimes the scheduling alone, I'm like, that's a nightmare. But it's also, you're exposing yourself to potentially sick kids, right? So a lot of times parents tell me, well, I don't want to give my child all these vaccines. I'm going to space them out. And I don't think they're at risk because they don't go anywhere. I hear that a lot. They don't go anywhere. They're not in daycare is kind of what they mean. We're not traveling. They're not in daycare. But I'm like, you are going places. Like, you probably take your kid to the grocery store, or you go to the library, or you visit, your family at a family party where you see a bunch of people. And then you're going to my office where, guess what? Sick kids go all day long, right? And so you don't know in the waiting room what you might be exposed to, or even, coming in and out of the office or whatever. And that's just more times that you're exposing them there. So that alone, to me, I just think, why not? You're here, you're in the office, let's follow the schedule, get things done, and then you don't have to keep coming back and making all of these appointments and trying to keep track of something that really we've already thought through for you, the best approach to do it. So that's really the easiest and safest way to approach it.
Great. Thank you. Thank you for those thoughts. I will also add one particular point. If you compare the vaccines that we are using now to what they were 20, 30, even 40 years ago, the amount of antigen, the reactive substance within those vaccines has been decreased significantly. So even though we're putting more types of vaccines together, the total antigen load has decreased. And again, it's very, very important to get this to the kiddies so that their immune systems can functionally create those antibodies. And we have those schedules, we've worked it out, we've looked at the data. So it really is, as both Dr. Lockwood and Dr. Handy stated, most important that we try to stick to that schedule. All right, well, thank you very, very much for all of your input. And with that, we will go to some final thoughts from each of our panelists. And I will go in the reverse order from our introduction. So I'm going to start with Dr. Rothkopf. If you can give us some final thoughts, sir.
Well, thank you everyone for being on tonight. I think, as alluded to earlier, in the internet age, when there's just so much information, so many, people who are influencers, self-proclaimed experts, whatnot, it's easily to get overwhelmed and wonder what the right thing is to do. So, we wanted to put this together for the community, and give everyone the opportunity to, kind of hear it from the horse's mouth, as the saying goes. And, thank you for being here with us tonight. And, just remember, it is a partnership between patients and physicians. And, ultimately, we are here for all of you and want to do our best to provide the best care for you and your families. So, please ask us the questions. If something you've heard is unsettling or concerning you, talk to us about it. Again, there's a lot out there, especially in the vaccine realm. Please ask us the questions. We won't be offended. This is what we're here for. This is what we went to school for and trained for many years for. Thank you.
Thank you, Dr. Rothkopf. Dr. Handy, final thoughts.
Sure. Yeah, no, I think we covered a lot tonight on kind of how we do love talking with patients and families, and I think we're just doing it day in, day out, and that's what we signed up to do. So we do want to hear questions. We really love having the conversations, and I think families out there should remember that despite the news headlines, despite the anxiety, despite the fact that we have to have special webinars about this, the majority of families, the vast majority, choose to vaccinate their children. So the normal thing here in our community is really to vaccinate. And I think most families are aligned that we really want to protect our community and our kids from these vaccine preventable diseases. So despite all the chaos that's going on, I think most families are going in and getting their vaccines. And I think that's helpful to remember. Questions are good, conversations are good. But at the end of the day, most of our kids are really getting protected. And that's what we all are aiming for.
Thank you, Dr. Handy. And Dr. Lockwood.
Yeah, well, so many of the sentiments that were already said, I would echo. Again, the AAP is a great resource for you. So beyond your pediatrician, the AAP as well as the Vaccine Education Center at CHOP are great places to get kind of a broader view on these topics. Also places that you can follow on social media for guidance. And really, again, your pediatrician is there for you, and we want the best for your child. We really want to keep your child happy and healthy so that they can be focused on growing up healthy, thriving, going to school, and attending all their activities. And really keeping them out of my office except for their well visits is the goal. And so that's what vaccination allows them to do. And I can't say anything stronger than I've vaccinated both of my children fully for every vaccine that they could get, and I wouldn't do for your child what I wouldn't do for my own.
Thank you so much, Dr. Lockwood. Well, we've come to the end of our program, and I want to thank all of our panelists for this fantastic information. I will note that we are archiving this production so that it is accessible. There was a lot of information that came out. If you might have missed a few things going through, if you want to watch it again, you're certainly more than welcome to do so. That can be accessed. If you want to share it with your friends, so much the better. We want this information to get out to everyone as best it can. So please do share this information. It will be available on the county Facebook page. We're also going to really emphasize it again for National Infant Immunization Awareness Week, which is coming up at the end of this month. With that, I want to again express my thanks to the panelists and to personnel behind the scenes. We have Caitlin Tucker and Teresa Harris from the Montgomery County Health and Human Services Office of Communications, and they have helped us with their technical expertise for this program. Kaylin Roberts, representative of the Montgomery County Immunization Coalition, thank you so much for your assistance as well. Two final thoughts I will leave you with. Number one, we'll be starting a campaign from the Office of Public Health in the near future. I'm trying to come up with a real catchy title, but right now it is Know Your Immunization Status. We've had a couple of concerns about outbreaks of things like measles in the county, and we think it's really, really important for adults to know what their immunization status is. So we're going to be trying to get this out to the public where you check your vaccine history ahead of time. And there are various ways of doing that. There's registries, there's records, there's blood tests if you don't know if you've had a vaccine or not. But it's best to know these things ahead of time before you potentially are exposed to one of these diseases. And my final comment is, as I mentioned before, and as I always mention on these programs, your first and best source of information, not just for vaccines, but for medications, medical treatments, all of the things that relate to medicine, are your trusted healthcare providers, and in this case for your kids, your child's pediatrician. These are the ones who, as have been mentioned, have nothing but your child's best interest in mind, and they are the ones who can give you the most up-to-date, scientifically based, logical, unbiased information possible. So please consult with them, please ask your questions. A final thank you to everyone, and a specific thank you to all of those who joined us this evening. I hope this was a worthwhile experience for you. And thank you again. Have a good evening and have good health.